Hello, everybody. Welcome.
Yeah. Okay. So I'm going to start slowly. Yeah. Okay. So hello, everyone, and a very warm welcome to all of you, each of you. We have people from all over the world participating in this meeting, and I want to thank you all for setting aside time to join. I genuinely believe we're all going to enjoy the presentations and discussions and learn from each other. It's going to be a great webinar. Thank you for joining. And I hope you'll agree with me afterwards. It was a good one. So again, welcome to this webinar on capacity strengthening for improved preparedness against arboviral threats in Africa. If you're in Asia, the Americas, or wherever you are, you will know that what we're about to discuss today is equally relevant to you, as these arboviruses are also expanding to your region or will be reaching you soon enough. This webinar is presented to you by the Resilience Against Future Threats project, which is shortened to RAFT, and it's funded by the UK government and implemented by a consortium of partners led by the London School of Hygiene and Tropical Medicine, but it includes partners such as the Center for Research in Infectious Diseases in Cameroon, the Institute Pierre Richer in Côte d'Ivoire, Imperial College, Mahidol University in Thailand, Malaria Consortium, and the National Institutes for Medical Research in Tanzania. We're privileged to have with us today collaborators from several other institutions, which we will mention as we go along. But I would like to mention World Health Organization, WHO in particular, from which, as you will see, we are drawing top-level contributions in various forms. To all of these partners and colleagues, a very sincere thank you for contributing to this event today. So I need to explain the webinar process, and I'm going to ask Wulan or Olivia to pull up the slide that shows the flow diagram. Okay, I just need to get rid of bits and pieces over here. So not sure if you can see my cursor, but the top box, so we have a plenary opening, which is what we're busy with now, just the workshop introduction and process description. Then we're going to have the 5 presentations, wonderful presentations to look forward to. That's going to take about 60 minutes. 4 of the presentations will be, sorry, could everyone just mute themselves? There's some distracting background noise, sounds. So 4 presentations of 10 minutes each, and then 1 presentation of 20 minutes. Then we're going to break into 3 breakout groups. Please take note here. This is important. We've got 3 breakout groups, and each of you will be going self-selecting which group you would prefer to join. So the 3 groups are, firstly, Group 1, Research Gaps and Needs. Facilitators there will be Sean Clark and Joe Lyons from London School, supported by Dr. Popo Aung. And then the networking breakout group, group number 2, facilitator there is Dr. Florence Fouquet, supported by Dr. Callista Chan. And then we have the 3rd group, the capacity strengthening group, where the facilitation will be shared by myself, Dr. Corinne Merle, and Dr. Raman Vilayudan, ably supported by Sobiha Wulandari. Everybody knows her as Wulan. So that's 60 minutes. I want to suggest to our facilitators that if you finish ahead of time, let everyone take a 5-minute break and then reconvene and move to plenary session. So at some point, we'll have a comfort break for 5 minutes. Then we reconvene in plenary for the group feedback. Each of these groups will then spend 10 minutes giving group feedback. And there's a question and answer session. I need to apologize here because time is so tight. We have so little time. There's no question time immediately after the 5 presentations. Please save your questions. You can pop them in the chat box, but the response will be during the Q&A session towards the end of the webinar. And then we're going to discuss briefly the way forward, and that's our workshop then. So, oh my goodness, where am I now? So before we move to the presentations, please note that this webinar is being recorded. I don't know what we're going to do if you refuse to be recorded, but just be aware that you are being recorded. And you will be able to access the recording of the whole workshop, the whole webinar, plus the 3 working groups within the next 2 or 3 days at a URL, which will be screened at some point during this webinar. Also note that only the panel members are live, meaning they can turn their audio and video on and off at will. Our audience members, unfortunately, you must raise the little hand icon if you wish to speak, and we will unmute you. Please feel free to use the chat box to communicate and share comments and questions. Please, we'd appreciate it. If you have a comment, a suggestion, or whatever, pop it in the chat box. All those comments and suggestions will be captured and recorded and will be extremely useful. If you wish to direct your question to a specific person, such as a particular speaker, please precede your question with the name of that person. Note also that because of lack of time, we are pushing the Q&A session to the end of the webinar. And then finally, right at the very end of the webinar, we will screen a short feedback poll just to assess your opinion of the webinar. It was way too long, it was too short, you should have split it in 2, or whatever. It's a very short 1 minute of your time, but it helps us, and I'd be grateful if you can just quickly follow the prompts. Okay, so let's move to the presentations. Our first presentation is by Dr. Raman Velayudan, who's going to update us on global trends and an introduction to the Global Arbovirus Initiative. Dr. Velayudan is well known globally, and he is head of the Veterinary Public Health, Vector Control and Environment Unit at the World Health Organization's Department for the Control of Neglected Tropical Diseases. He's the global focal point for dengue prevention and control, integrated vector management, and he coordinates dengue and other arboviral vector-borne disease control activities at WHO headquarters. Raman joined WHO in 1989 and has been leading sterling work ever since. So Raman, we look forward to your presentation. Thank you so much for your time. Over to you.
Thank you very much, Leo. I hope you can see my screen well. And
yeah, it looks good. Thank you.
Thank you so much. So just to begin the topic, I'm just going to basically touch a little bit on the global trends and introduce to the Global Arbovirus Initiative, which was launched on 31st of March this year. And basically, the reason why we are having this Global Arbovirus Initiative is really because during the pandemic, most of our work were affected, but the arboviruses were continuing their rampage in many countries, and we had several reports in the media of millions of cases of dengue confirmed in, for example, in places like Brazil. There was also outbreaks in India. And similarly, we had chikungunya outbreaks.
Can you get more water from? Ask Owi to give you 1 bag of.
Sorry, there is a disturbance. So with this situation, we also had yellow fever. So in 2021 alone, we had 9 countries in the African region affected by yellow fever. So we had multiple arboviral diseases affecting many countries. And of course, the worst scenario was in 2019 when we had a large number of dengue outbreak in several countries. So WHO was preparing to launch this, but COVID affected us. And so we had been working behind to really come up with this document as soon as we get a clearance from our senior management. And actually, this Global Arbovirus Initiative touches at this moment on Aedes-Borne diseases. So essentially, we are covering 4 diseases: dengue, chikungunya, yellow fever, and Zika. And we also have mapped out the countries affected. As you know, dengue alone affects about 130 countries, chikungunya around 118, and Zika around 80 countries all over the world. So we have just mapped it out, and you can see that there are countries with multiple arboviral infections. And most of these countries are more or less endemic for Aedes. It is well established. And this mosquito, especially Albopictus, is spreading quite fast in many parts of Europe as well. So chikungunya, just to touch on, we had big numbers in Brazil, Cambodia, Philippines, and India in 2021. Zika also, we had more than 10,000 cases recorded in several countries of South America, and also in India. And then, as I had said in the beginning, we have this whole area of Africa being threatened with yellow fever, and it is still an ongoing outbreak in many of these countries. So in terms of dengue, as I said, 2019 was a very bad year. And then, of course, we continue to record cases in 2020, 2021. And this year also, it is quite bad in few countries. And we are still tackling dengue in at least half a dozen countries globally. On an average, if you take dengue, as a trend shows, it is one of the only communicable disease which has exponentially grown by 6-fold since 2000. And this was also reported in the Lancet. So we really have to do something about arboviruses, and especially with increased urbanization, this is going to be a bigger problem. So an integrated approach was what we wanted to do, and our senior management was in favor of it, to strengthen any detection, prevention, and response for Aedes mosquito transmitted viruses. We want to advance innovations in vector control, diagnostics, and medical interventions, improve supportive and clinical care, and thanks to our clinicians, the mortality rates have been kept low. Empower communities to support these efforts. And also this Arbovirus initiative, we really want to raise a global alarm, convene partnership across all sectors beyond health, including agriculture, urban administration, and so on, and enable the utilization of our very limited resources to the most effective way possible. So this initiative has actually 6 pillars, and I will be touching on each one of them. The first one being the monitoring risk and to anticipate. Second is to reduce epidemic risk. Third is strengthen vector control. Fourth is to prevent and prepare for any epidemic. Enhance innovations and new approaches is the 5th. And the 6th one is the partnership part. So in terms of monitoring risk and anticipation, we have really 2 major activities, basically to develop a global risk monitoring framework using a One Health approach. Number 2, to forecast and model potential epidemics and pandemic scenarios. Now, there's a lot of work going on this. And before I continue, I also need to say that this document has gone through huge consultation at the end of 2021 among all stakeholders, and all their inputs have been incorporated. And this document we hope to publish very soon. So among these activities, we are looking at the drivers of arbovirus transmission, integrating data systems, mapping risk, global dashboard, integrated dashboard. There is a lot of modeling work being initiated. We want to validate and recalibrate, and if possible, arrive at forecasting. The second one is to reduce epidemic risk, and this is mainly to strengthen early detection, increase capacity to perform epidemiological investigation, improve response to arbovirus outbreak, and increase population protection through vaccination wherever possible, especially in the case of yellow fever and the eye strategy. So here we have several activities which includes early warning systems, timely confirmation, We are encouraging countries to have integrated surveillance. We need to increase capacity, which we will discuss today. Cross-border exchange of information, standardized reporting, integrated strategy for outbreak management, better case management, and as I said earlier, vaccination wherever possible. In terms of vector control, we want to enhance surveillance, strengthen vector control, and increase preparedness in urban and densely populated areas. And here again, most of these points overlap. There is capacity building, guidance on vector surveillance, viral surveillance of vectors, environmental management, advanced research, which is continuing, and we are seeing many new tools coming through, sustained community support. We want to encourage cross-sectoral engagement. We are also working very closely with urban health, and we want to have sustainable vector control tools, something like the ITNs in malaria. The fourth pillar is to prevent and prepare for potential epidemic or pandemic, where we want to enhance global coordination among stakeholders, strengthen global surveillance mechanism, and for rapid response, strengthen community engagement, and develop and strengthen countermeasures. Now here again, there is overlap. We are encouraging global network, mapping funding activities if possible, rapid reporting of risk, community awareness, risk communication, and multi-sectoral partnership. The fifth pillar is to enhance innovation and new approaches. And as many of you know, we need to develop integrated public health research agenda, support development of innovative countermeasures, including vaccines, drugs, diagnostics, and vector control tools, and develop new tools and approaches for public health preparedness and response. So here we are talking about integrated research agenda, burden estimation, which is very important for advocacy, risk factors and the role of serotypes, inclusion of social science. We want to work further on the biomarkers of severe disease, integration of preventive tools. Of course, as I said, antiviral, there is a lot of work going on, and integrate it within the One Health approach. The last pillar is, of course, to build coalition of partners. And this is where we are really looking forward to all of you. And this is the main purpose of this webinar today, to strengthen partnership among stakeholders and partners, enhance communication with stakeholders, coordinate most of these activities, seek synergy with partners, map partnership regionally, and have a good communication plan with the IT platform for dissemination. So these are the key 6 pillars for the Global Arbovirus Initiative. And we are beginning our work. There is quite a good deal of work currently being initiated on Pillar 1 and Pillar 2 with some funding from the US CDC. And this is mainly to look at global risk monitoring framework and using the One Health approach. And the Pillar 2 is mainly to develop an integrated strategy. Also, we are coordinating the global laboratory network. We are not creating anything new. We are building on existing networks, strengthening local capacities for epidemiological investigation to inform prevention and response activities. So these works are in progress, and we will be starting with other pillars too, as and when resources are made available. And we are working across in WHO among the 3 or 4 departments, and all of us, we meet very often, and we are working across all levels of the organization. And this Global Arbovirus Initiative, we hope, will trigger greater interest in this area of work, because Aedes-Borne diseases continue to threaten urban population, and the problem is going to get increasingly more as years go by with increased urbanization, which is happening right now. And we anticipate 70% of the world population will be in urban centers by 2030. Before I end, I also wish to thank the Malaria Consortium, London School, and all the partners for organizing this webinar and giving us this opportunity. Thank you very much. Leo, over to you.
Sorry, I was muted over there. So Rahman, again, sincere thank you for sharing those developments with us. What a wonderful foundation for the other presentations to build on. Really excellent presentation, very useful information. It's very impressive, that trend you showed, the increase in cases over the last 2 decades or so. So thank you for sharing that with us, Raman, much appreciated. And also thank you for your willingness to collaborate with us, share your time, and be part of this team. So we're going to move on now. Our next presentation is a summary overview of the WHO TDR survey on surveillance and control capacity in Africa. And the presentation will be split between Dr. Emmanuel Chanda and Dr. Gildas Yawedu. I should mention that we all, listen to this, we all share the privilege of being the very first general audience to receive the findings of this impressive survey, which in fact has not even been formally published yet, but it will be in the next few weeks. So Dr. Emmanuel Chanda is a medical entomologist and a vector control specialist with extensive experience in combating vector-borne diseases. He's currently technical officer for vector-borne disease control in the WHO Africa region. And then co-presenter is Dr. Gildas Yawedu, who is also a medical entomologist, specializing in the control of vectors and vector-borne diseases, with additional training and experience in epidemiology. Prior to joining TDR in 2020, he provided technical support to WHO's Global Malaria Program in the development of various guideline documents. Both these gentlemen are co-authors of the WHO report that they will summarize here for us in this presentation. And I should perhaps also mention that Dr. Raman, Dr. Florence Fouquet, and Dr. Corinne Moll, who's just joined us a couple of minutes ago, are also co-authors, and all of these good people are helping us today in one way or another as speakers or breakout group facilitators. We look forward hugely to what you are about to share with us, Emmanuel and Gildas. Thank you. This is a 20-minute, roughly 20-minute presentation. Given the importance of the subject, we're allocating them more time. Thank you. Please proceed, Emmanuel.
Thank you so very much, Professor Brack, for this opportunity. I'm going to set the scene for the presentation that we're going to give together with my colleague Gildas. But I would like to, first of all, acknowledge the fact that the African region is not exempt from the threat of arboviruses, like we have heard, and these include yellow fever, dengue, chikungunya, as well as Zika. But also there is an increase of zoonoses, such as Crimean Congo hemorrhagic fever, Rift Valley fever, and as well as West Nile fever. By 2020, the region had actually recorded an excess of 220,000 cases of dengue. And I would say outbreaks and other emergence-related issues on arboviruses are increasing and continuing in Africa. And we have seen dengue persisting in Kenya. In 2021, about 800,000 cases were recorded with 2 deaths. And then the following year, meaning this year, 2022, the number of cases tripled, but the deaths remained the same. And we have also seen this year in Cabo, not Cabo Verde, but in Sao Tome and Principe, dengue outbreaks continuing. And we have also seen the first ever case of dengue in Niger. So these chilling statistics do actually indicate the scale of the problem to an extent, and they are actually, I would say, a tip of an iceberg the problem, because we do not know the extent of the burden of arboviruses. The region is host to quite a number of factors that facilitate transmission, in addition to, of course, what we all know, the effect of climate change, as well as the invasion of the invasive Aedes albopictus on the continent. Also, the increasing detection of resistance to mosquito vectors of arboviruses. We have seen some kind of reactive approach to combating of arbovirus diseases in the region, and countries do not have programs that are dedicated to arboviruses with inherent surveillance systems. Although at present, there are some countries that are making some proactive actions, like Cameroon, Nigeria, Mozambique, as well as Eritrea, in terms of capacity building and surveillance. But the African Region Office leadership are committed to strengthen health systems for combating arboviruses. And this relates to putting in place strategic investments as well as actions vis-a-vis improving and expanding the TORs for the African Network for Vector Resistance to include arboviruses, and as well as providing technical support to countries, conducting capacity building, as well as research, be it operational or advanced research. But the region is also ensuring that there is alignment of actions with available global guidance recommendations, as well as global and regional initiatives. And in this regard, I'm referring to the global vector control response to enhance IVM implementation. I'm also referring to the NTD roadmap, as well as the global arbovirus initiative that has just been presented. But we are also riding on the optimism surrounding other partners that have got vested interest in arboviruses. In 2021, an evaluation was conducted across the African region to assess countries' capacities in terms of arbovirus surveillance, control, and epidemic response and preparedness. And this is with a view of informing development of programs at country level, riding on already existing health systems. But just last month, the region had a framework for integrated control, elimination, and eradication of tropical and vector-borne diseases endorsed, and this framework will facilitate establishment of health systems to enable integrated service delivery. I would end there and allow my colleague Gildas to go ahead with presenting the actual results of the assessment. Thank you, and over to you, Gildas.
Thank you very much, Emmanuel. Let me share my screen. Up. Yeah, up. Not this one. Up.
We can see that now.
Gildas, you had it up and then it disappeared. And yeah, just go back to your first slide. There we go. Okay, good to go. Thank you, Gildas.
Okay, so good morning, good afternoon, everyone. Thanks to organizer for giving us the opportunity to share with you the results on the African country capacities for the surveillance and control of arboviral diseases. So, as you know, there are more and more cases of arboviral diseases in Africa, and this is intimately linked to the increasing factors on the continent, such as population boom, urbanization, deforestation, etc., etc. Aedes vectors are present, and arboviruses are circulating on the continent. And other key matter is that African countries have less experiences in the control of arboviral diseases compared to other regions. So it's therefore wise to assess African country capacities to prevent, detect, and respond timely to arboviral diseases outbreak or epidemics. And we conducted this assessment through a survey in all 47 countries of the WHO African region. We use a self-administered questionnaire as tool developed on 45 indicators, exploring capacities in 7 key domains, which were disease surveillance, diagnosis and case notification, management of cases and severe cases, biological surveillance, routine vector surveillance and control, community sensitization and participation in non-epidemic periods, preparedness for arboviral disease outbreak or epidemics. Then we scored all answers. 1 means that the country is on track for the indicator if answers match completely on the definition of this indicator. 0.5 means in progress if answers match partially on the definition of the indicator. And of course, 0 means means not on track if answers did not fulfill at all the definition of the indicator. And we finally used this scoring to classify countries in 4 groups based on the total scores. You have 0 to 50 adequate capacities, and so forth until 90, between 90 and 100% adequate capacities. All 47 countries of the African region participated to the survey and validated the report, the result of the report. And the map here shows countries according to their capacities, and the color gradient is intuitive. According to, can you hear me?
Yes, yeah. There's a bit of background noise, but that's okay. You're coming through loud and clear. Thank you, Gildas. Please proceed.
Okay. So the map here shows countries according to the capacities. And the color gradient is intuitive. According to the classification, we have 24 countries that tick to the box of inadequate capacities, including the most populous countries in Africa. I mean Nigeria. 17 countries with partial satisfactory capacities, and only 1 country has adequate capacity. I mean Algeria. At the whole, the regional capacities are less than 50%. And by breaking down by domains, the region has partial capacities for disease surveillance, diagnosis and case notification, outbreak preparedness, as shown on the map here. However, the region has inadequate capacities in 4 domains. I mean, the management of severe cases, biological surveillance, routine vector surveillance and control, and community engagement. At sub-regional level, West Africa shared similar trends with the region. Central and Eastern Africa have Central and East Southern Africa have inadequate capacities in 6 domains out of 7, as shown on the charts. West Africa has more capacities than the other sub-regions in disease surveillance, diagnosis and case notification, and outbreak preparedness, as shown on the charts. Here you have a classification of the 7 domains at the regional level, from lower to higher scores. In each domain, I pointed out one key specific challenge. For instance, you have no national guidelines on clinical management of cases of arboviral diseases, no or limited routine surveillance on arboviral diseases, no or few outreach programs including arboviral diseases, no or few programs dedicated to entomological surveillance and control of Aedes vectors, no or limited confirmation of suspected and positive cases of arboviruses and quality control, no or irregular epidemiological surveillance on arboviral diseases, no contingency plans including arboviral diseases, outbreaks, or epidemics. All countries reported 3 recurrent challenges. They relate to training, they were technical and financial, they relate to limited community awareness on arboviral diseases. Other challenges to share with you is the express needs of countries for adequate detection of arboviruses. As you can see on the screen, 77% of them express the need of additional staff training. Same thing for laboratory equipment, and 47% of them need additional staff at full-time equivalent level. To recap, weaknesses are related to the first 4 domains, while existing capacities are related to the last 3 ones. And we do think that to address the 3 recurrent challenges mentioned earlier, countries need clear training plans emphasizing staff needs, type of training, frequencies, and budgets. They might consider online GBCR courses, training for free or distance and e-learning programs, including existing MOOCs. They have to lobby legislative and funder at national and international levels. They may consider to raise awareness campaigns on arboviral diseases for increasing community sensitization and engagement. Lesson learned, we noticed a good engagement of all countries in the survey. Participants were very mindful of country strengths and challenges. Most countries are interested in strengthening their capacities, of course. And currently, none of the countries except Algeria are adequately prepared to detect, manage, and timely respond to an arboviral disease outbreak. I would like here to keep in mind that because of the survey was based on self-administered questionnaire, and because of COVID-19 related activities during the conduct of this survey, we may have dealt with possible bias in responses. For instance, we found in the literature review that Aedes vectors are present and arboviruses are also circulating in a couple of countries which had not reported this information in their answers. That's good to keep in mind. We do think that strengthening biological surveillance, better preparing countries for managing severe cases, and increasing community awareness and engagement in better control activities are 3 key challenges to address. The regional report on the survey is finalized and designed for publication. Both English and French versions are currently under the WHO web validation processes. The reports include a regional and sub-regional analysis by domain, a chart on the 47 countries along with the indicators we used and the weaknesses reported by countries. 47 one-page summary sheets developed for each country based on the transmission and burden of arboviral diseases in the countries. A summary table with potential ways to move forward based on the existing WHO and PAHO guidance documents. At the global level, this survey will feed a global report as part of the Global Arboviral Initiative Raman was mentioned earlier. At a regional level, we plan the organization of a regional workshop to present and discuss the results. That's what we are doing now. Other items such as capacity building needs, training, technical assistance, and experience sharing need to be discussed. All this in close collaboration with the Global Arbovirus Initiative. We also do think that addressing the key challenges identified in this survey is a significant step forward to protect communities against the growing threat of arboviral diseases in the African region. I would like to thank all these resourceful persons I worked with, Corinne from WHO TDR, Ramon from WHO NTD, Emmanuel from WHO Regional Office of Africa, and Florence from WHO TDR. Special thanks to Ingrid and Diana from WHO Department of Emergency, all 47 WHO country offices we work with, WHO entire country support team lead from the 3 sub-regions, the national health authorities within the Ministry of Health, and researchers from the African region. I need to stop here. Thanks, ladies and gentlemen. Back to you, Leo.
So, thank you, my gracious me. What a really in-depth expose, as it were, of the, you put together the graph shown earlier on the rise in the steady, consistent, sustained increase in case numbers. And then you put that together with this showing us the depth and the breadth of the capacity shortfalls to deal with that rise in arboviruses, dengue, for example. And it's a wake-up call, it's a wake-up call where we need to sit up straight and recognize there are, dark clouds looming and coming our way, and we had better prepare for what is a steady trend. It's not going to go away. It's just going to keep on increasing until we improve our capacity to deal with it. So for that lesson, Emmanuel and Gildas, we are very grateful. Very, 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 very valuable information you shared with us. Very useful. Now we need to respond to that call that you've made and the awareness you've created amongst us. If there's one thing we've achieved with this webinar, it's to make everyone aware of what you've just told us. The steady rise in arboviruses and our absolute unpreparedness in dealing with it, and the need to engage effectively with what is lying ahead of us. All right, so Emmanuel, Gildas, thank you again so much. My goodness, we have an excellent series of top quality presentations lined up today. Our next speaker is Dr. Florence Fouquet, who will share with us some could I ask those persons that are not muted, please just mute yourselves. Our next speaker is Florence, Dr. Florence Fouquet, who will share with us, who will share some information regarding best practices in establishing regional and global networks for vector-borne disease prevention and control. Dr. Fouquet started her career at the Polytechnic School of Zurich to work on the biological control of insect vectors and pests. And then Florence joined the Pasteur Institute and its international network for more than 20 years. And in 2014, she joined WHO TDR, where she's in the implementation research unit. Florence, you are addressing us on a very important topic, the issue of networking, and you're going to lead the breakout group for us on that topic. We look forward to learning your insights in the presentation. Over to you, Florence, please.
Yes, thank you, Leo. Thank you for the presentation and the invitation to deliver this short speak about networking. I will not really emphasize that we need networking, but I will try to show you some basic elements that are necessary for a workable and a sustainable networking. So I'm going to sharing my presentation now, and here is the sharing, and I put it in view mode. Can you see it in the Diapo mode?
It looks perfect, Florence. Please
That's
proceed.
excellent. Thank you so much. So
Thank you.
the best practices in establishing regional global networks for vector-borne disease prevention and control, but I could have also added local network because all levels of the networking are important. So why do we need to establish networking? I put together here the challenges in waterborne diseases. These challenges are huge. Challenges are linked to the vectors, different vectors for the same disease, different bionomics for the same vector. The challenges are linked to the host. We have different hosts for the same pathogen. We have fluctuating early variable levels of immunities, and we have challenges linked to the context and the environment. We have very different environment for some vectors, such as the Aedes. We have the climate change, the urbanization, and it is obvious that one single institution, a group of people cannot work on all these aspects alone, and they must exchange with the rest of the community, both the scientific community, but also at the government level and at the communities and population that receive the care level. The necessity for networking on arboviral disease has never been so huge, I would say, because of the increase of this threat and risk, and also because we have, I would say, boxes here that show that all the activities cannot be taken separately. The detection of arboviral circulation necessitates the exchange between countries because the arboviral disease do not know borders. Then we must have surveillance networking, facilities for diagnostic, lab networking, access to health facilities. Sometimes it's easier to go across the border for a health facility than to take the health facility in the own country. Availability of guidelines and material that must be harmonized, reporting system, early reporting, of course, and training of the staffs. In the same way, the response and prevention must be evidence-based and coordinated. And then all the elements included from the treatment to the containment, then they need networking. I show you here that networking can be seen at different levels, geographical level, but also sometimes the topics. So, for example, you can have networking between different regions within one region, but you can also have networking within countries having the same type of burden. This is what I show in the blue circle here. There is a very good perspectives for networking between African countries that are currently experiencing high burden of arboviral disease and the American country that are experiencing the same burden. How do networks are working? So this is a bit more of theory, but nevertheless, it's important to understand the kind of network you want to build up. So the role of a network is to provide ways and tools for individuals or groups to interact. This is what the networks are for. A functional network must have objectives. Then you can evaluate the activities against the objectives. And the type of network that you want to build up, you can be a ring, a star, a line, a tree. Each of these networks have advantages and disadvantages, but they must fit for the purpose. When you have a strong leadership and as I would say a kind of a strong coordination, then the star type of network is the one we would prefer. On the other hand, if you have something which is more flexible, in the exchanges and the leadership, then the fully connected may be the solution you want to take. Then another bit of theory around the network, building network to identify the priorities that we want to touch. Start first by determining the objectives of the network. Then you move on to establishing the partnership. They must have common objectives. Agree on a leadership or not, or more than a leadership. Establish some task group, raise funds, and then go on into the activity, 1, 2, 3, and activities. And the next and last step is to monitor and evaluate the activities against the objectives. And then you can evaluate if your network purpose is fit or not. And if you need to, I can say, re-engage into other partnership or into different objectives or different activities. Since I want to make this presentation quite quick, I'm giving here some example of networks that have been set up by the support from TDR. So the first one is the CariVec net. It's a network on arboviral diseases in the Caribbean region. We started activity with the Caribbean countries, and this network is led by CARFA, the public health agency in the Caribbean, in 2015. So it is 7 years ago. And this network still alive, very active. The objective have been well established, the leadership too. The partners are now the 30 countries represented in the circle. The network was officially launched in 2017. It received financial support by CDC, CARICOM, France, European Union. And if this network was able to receive funds, it's because it had very clear objectives and activities. Working groups were established for surveillance, diagnostic, case management, and vectors, and now they are moving on to the activities. An assessment of the facilities and capacity was completed in 2019. And more recently, we had a webinar on the advances and innovation in vector-borne disease prevention and control that was held in September 2022. Another network that was started through the TDR support is the Worldwide Insecticide Resistant Network called WIN. So you see here that this is more a star-like network with IRD being under leadership and running the network. And this network has allow WHO to release the determining discriminating concentration of insecticide for monitoring resistance in mosquitoes. Very important document when we want to know the status of insecticide resistance in Aedes mosquitoes, which is an important topic, as you know. Another few networks that we are involved in or working with are something around data sharing. So we are working with the Global Biodiversity Information Facilities on data sharing. And we have recently released a special issue in collaboration with them for papers on data on vectors. And these are in an open platform to be shared to the communities. And we will launch a second special issue on data papers at the end of this year. Another area we are collaborating are training and capacity building, and we are collaborating with the Global Vector Hub under the ArcTech company, which are working on the platform that support a directory, a global directory on courses of medical entomology. And then we are actually developing further activity with the Global Vector Hub and moving forward to provide more information and capacity building access worldwide, and in particular to the country that are in need of that. So just a very key conclusions. The challenge for emerging and re-emerging arbovirus diseases are global, and the solution are contextual. That makes the problem hard to solve because it cannot be solved at the global level. It must be solved at the local level requiring the involvement of partners at different levels. The magnitude of the change enhanced the need of exchange, collaboration, and coordination. And these needs extend to different disciplines and sectors. The building of the network must be based on the objectives which are specified and achievable, the partner, the leadership, and the steps to coordinate the activities. And I also would like to highlight that the situation, even local, are now completely interdependent. What is happening in one corner of the world will soon happen on the other corner of the world. And this is why we need so much networking, but not in many directions and with no sense. What we need is to define priorities, objectives, strategies, and activities. And I also want to enhance that the weaknesses of this networking should be the one we must work on, because they are the more vulnerable place. So networks will provide the expected achievement only if well structured and sustained. Thank you very much for your attention. And just this announcement, quite old now, but showing what we did with the WIN network.
Florence. Yeah, no, my goodness, thank you so much for that wonderful, wonderful overview there of the different kinds of networks, their attributes with the central node and then interconnected, giving us some examples in different parts of the world, and also making it clear that if you want a network, clearly define what are the objectives of the network. What is its reason for existence? So I cannot think of a better person to lead our group 2, the networking breakout group. Sincere thank you, Florence, for a very insightful presentation. So we now move on to a best practice case study of monitoring for the presence of arboviruses in both the mosquito and vector hosts. And for that, we have Professor Mariki Venter to talk to us on the South African example of human and vector surveillance for selected arboviruses. Professor Venter is head of the Zoonotic Arbor and Respiratory Virus Research Program at the Center for Viral Zoonoses at the University of Pretoria in South Africa. Professor Venter has held multiple positions in her career, including as One Health Program Director, Global Disease Detection Center at the United States Centers of Disease Control and Prevention. And that was from 2014 to 2016. We thank you for being with us and sharing your expertise, Prof. Venter. And we look forward to your presentation. Thank you, Mariki. Over to you.
Thank you, Leo. Thank you very much for the invitation. I just want to correct, I was the GDD Global, after GDD Director for One Health in South Africa for US CDC, not in Atlanta.
My apologies. Yeah.
Okay, so thank you for all the interesting talks. As you could see, South Africa actually falls under one of those that arboviruses was probably a little bit neglected. And so I would like to tell you about the research program that we have at the University of Pretoria that focus on arboviruses. That's mostly privately funded or internationally funded. A lot of it had actually come from GDD at the time, but we've also had EU funding and other local funding to do this work. So I'm the head of the Zoonotic Arbor and Respiratory Virus Research Program in the Department of Medical Virology, and we're also part of the Center of Viral Zoonosis. Okay, so this table shows a couple of selected arboviruses of interest and importance in Southern Africa, but also then my focus will specifically be South Africa. But as most of you probably know, The most important zoonotic arborviruses falls in the families Togaviridae, which is the alpha viruses, the Flaviviridae, the flaviviruses, and then the Bunyaviralis group, which contains the former Bunyaviridae. Okay, and so under the alpha or the Togaviridae, the alpha viruses that's most common in southern Africa is Chikungunya and Sinbis virus, but then also other less known arboviruses such as Middleburg virus. The flaviviruses of interest to us is Zika virus and yellow fever and dengue, but they don't occur in South Africa. So the most common ones here is West Nile and Aedes-Borne virus, and then under the Bunyaviralis, Rift Valley fever, Crimean Congo, and then lesser known ones such as Shuni virus is of interest. So of all of these, most are carried by Aedes or Culex mosquitoes, with the exception of Crimean Congo, which I'm not going to focus on now. So most of these viruses are associated with either polyarthritis, fever and neurological signs, and then some also with hemorrhagic fever signs such as Rift Valley fever, and then of course things like yellow fever. So what really differentiates these viruses and makes a difference in the importance and distribution across Africa is really the involvement of Aedes aegypti or Aedes albopictus. So viruses such as yellow fever, chikungunya, and Zika in the sylvatic cycle circulates between non-human primates and endemic Arbor or endemic Aedes mosquitoes, while in the urban cycle they then get picked up by Aedes aegypti and Aedes albopictus, and humans become the reservoir host that can actually distribute it. And this is why we see such large epidemics occur in endemic areas. So in southern Africa, yellow fever, Zika, and dengue doesn't occur in South Africa, although it's in some of our bordering countries. And we sometimes see imported cases, mainly of dengue and chikungunya. Chikungunya outbreaks have occurred in South Africa, but this is mostly as a sylvatic cycle and not due to Aedes or Aedes aegypti and Aedes albopictus mosquitoes. The zoonotic arborviruses, on the other hand, actually plays quite an important role, although they are very much neglected, maybe also because they're not on WHO's list at the moment, so I hope you will take note. But these viruses, such as Aedes-Borne and Middleburg and Rift Valley fever, actually circulates between endemic Aedes mosquitoes, which is mostly floodwort mosquitoes, and different animal hosts, such as wildlife and livestock, and then can cause infections in humans as well, while West Nile, Sinbis, and then other viruses such as the Sutu and Shuni virus circulate between birds and Culex mosquitoes, and then also sometimes certain Aedes mosquitoes, but then will spill over during climatic events or during high rainfall every year into humans and other sensitive animals such as horses and other wildlife species, but these are normally dead-end hosts. They can, however, serve as a sentinel to see outbreaks occurring. So Rift Valley fever in West Nile is both endemic in South Africa. Rift Valley fever occurs periodically with only every 20 years or so, but can cause major outbreaks in livestock and then spill over into humans as well. While West Nile really occurs every year in South Africa. So the map on the right, you can see in the red is the countries where West Nile is frequently detected and reported as actual disease, while the rest of Africa, mainly serological evidence that they exist. But this is mainly because of probably underreporting, not the fact that it doesn't occur there. So at the University of Pretoria, we've had a One Health program going from about 2009 and still going on, where we look at sentinel animals and specifically look for bird fatalities, neurological signs in horses, livestock and wildlife, and then also for abortion and death in young animals and hemorrhagic fever signs. We will then look, so we have a veterinary network across the country of veterinarians that submit cases for this. We then look at Sentinel Sites for human cases, so do syndromic surveillance mainly for febrile and neurological disease. And then in areas where we identified outbreaks, we do vector surveillance and would specifically look at mosquitoes and culicoides, although we're also interested in other vectors. So over the period of about 15 years already, we've identified West Nile basically as occurring every year in horses with neurological signs, but we can also then show that it's co-circulates with certain other arboviruses such as Sinbis, Shuni, and then Middleburg virus as well, that I'll touch on briefly. So the animal surveillance really helped us to describe the seasonality of these viruses. So South Africa has a temperate climate, and you can see our outbreaks happens during late summer and autumn, between February and sort of June, when most arbovirus occur. We were able also to show then that outbreaks in animals correlate with seroprevalence in veterinarians, so veterinarians that submitted cases, with West Nile having approximately 7.9% and Shuni's 3.9% seroprevalence in people across the country. However, to really show that these viruses then is a cause of concern in humans, we first did a pilot study where we look at CSF samples that were collected from patients submitted, or specimens submitted from hospitals in the Tshwane region, that's the Pretoria region of South Africa, to the National Health Laboratory Services. So we collected samples specifically in the year 2017, which had actually quite a high number of West Nile cases in horses, and we screened this with flavivirus, nested real-time PCR, and a commercial West Nile IgM test, and confirmed this with virus neutralization test. We also do the alphavirus genus PCR, and we incorporate Sinbis and Middleburg virus probes, which is the most common viruses, but we'll run it on a gel as well to see if we see any other potential or alpha viruses coming up. And then we have a Sinbis virus commercial IgM assay that we do as well, and a virus neutralization test. And then Shuni virus, which was a virus that we identified in horses causing severe neurological disease, and we do an Autobunia virus PCR for this, and then a real-time PCR. So just a very brief summary, we could show that West Nile occurred in about 3.6% of patients with unsolved neurological disease in hospitals in this Tshwane region. And this was when we incorporated IgM assays as well. Shuni virus, that we only have PCR for, was present in about 5.4% of cases. And then Middleburg virus in 2.1%. Also, we don't have commercial test for that IgM assay. And then Sinbis we didn't detect in CSF samples for this year. We then established a more active surveillance program. This is part of the African network of improved epidemiology and diagnostics of common and emerging diseases. And it's a grant that we have with the Robert Koch Institute in Germany since 2018. So we've established 3 Sentinel sites at Kalafong Hospital, which is outside of Pretoria, and then 2 hospitals in the Mpumalanga region, which is next to the Kruger Park. And we've enrolled patients here with informed consent and case investigation forms with more a wider range of epidemiological information. Our case definition was really acute fever of unknown cause with fever, and then with or without neurological signs, but then also other signs of arboviruses such as myalgia, arthralgia, and a rash. So just briefly, we screened with the meningitis chip for 28 different pathogens, including the major arboviruses that's present in Southern Africa. And we could solve about 15% of cases for other pathogens, but we didn't detect arboviruses by PCR. However, when we incorporated the serological assays, we found West Nile in about 8.6% of cases, and Sinbis virus in 12% of cases. So this shows the results for West Nile through the pandemic, and you can actually see that West Nile contributed significantly to fevers of unknown cause in hospitals, and going from between about 8% or 6% up to 15% in 2021 in these patients. Just a brief summary then of what these patients look like. You can see we found them in quite a high number of neurological cases, about 64% of them had neurological cases, and then other clinical signs included fever, arthralgia, and myalgia. And then here's a summary of some of the neurological signs, which included febrile convulsions, encephalitis, seizures, and acute flaccid paralysis, with a fatality rate of about 5%. Interestingly enough, we also found Synbis virus quite prevalent, with about 12.7% that were neutralization positive. So after we did IgM assays, we confirmed this with neutralization assays. So it suggests that there's probably other arboviruses or alpha viruses involved as well. And we're busy screening for Middleburg virus with neutralization assays in these patients. What was also quite interesting is that a large number of them actually also had meningitis. So 55% of the positive cases had meningitis as well. We did identify a few co-infections with West Nile virus, but most of these were actually single infections. We then do vector studies around areas where we found animal cases. So we have Sentinel surveillance sites that were running between 2011 up to about 2018. This is in the Gauteng region where Kalafong Hospital is that I just told you about. And then also in Lapalala and Marikele, which is in Limpopo. And then next to the Kruger Park as well, and then in KwaZulu-Natal. And we basically, this was on farms and on wildlife reserves where we identified cases of arboviruses. We use tent traps, VG traps, as well as CDC light traps. And Leo was actually one of our big collaborators and our entomologists that helped us run these studies. So this is a result from a PhD student of mine, Melina Guridio's PhD thesis. This is really just showing the composition of the different vectors that she identified in the different regions. And you can see that in the Gauteng region, Culex mosquitoes are the most commonly detected, Anopheles mosquitoes in the Limpopo province, which is also more malaria areas. And then the Aedes mosquitoes were less common, but we did detect several different Aedes species in all the different regions. And so just a breakdown of some of these mosquitoes, the Culex mosquitoes, Culex iniventatus and Tyleri, and then Culex pipiens was common, and these are West Nile and also Rift Valley fever vectors. And then interesting, the Aedes mosquitoes, Aedes McIntoshi, which is also a Rift Valley fever vectors. And then we did actually detect Aedes aegypti in most of the regions, but it was quite low. So you can see here in the Kruger Park area, it was about 2.6% of mosquitoes that was detected during that time. This is published in a publication by Todd Johnson, who is also one of our PhD students, and you can see Leo and Melina was also co-authors here. And then our collaborators from Portugal, Paul Almeida. So we then screened these mosquitoes. We screened about 64,000 mosquitoes, and this was in 1,400 pools, and we were able to detect all these different viruses. The top of my screen is cut off, so I can actually not see what's standing at the top. But it's the flaviviruses in West Nile. You can see we detected in all the different sites, and then in the known and some new vectors that wasn't described before. We detected some other flaviviruses, mostly mosquito-borne flaviviruses, but also then found Synbis, other alpha viruses, and the Chikungunya viruses and Shuni in several different species. I'm just showing one tree for West Nile so that you can see the West Nile positive PCR cases that we found in humans, animals, and mosquitoes, mostly clustered in lineage 2, although we found 1 or 2 cases in animals of lineage 1 as well. Okay, so to conclude, West Nile and Synbis, and to a lesser extent, or lesser known alpha viruses such as Middleburg, and then the Chikungunya virus, Shuni virus, causes febrile and neurological disease in humans and animals in South Africa. Most of these cases occur during late summer and autumn. A One Health approach of syndromic surveillance in animals and humans and off-report vectors in the areas where we detected cases was effective in detecting outbreaks as well as reservoir hosts and vectors. PCR and serological testing in humans and animals is important, and genus PCR for screening vectors, but also animal and human cases help you to identify additional arboviruses that do not have a commercial test available. And then the availability of specific diagnostic tests, surveillance programs, and clinical awareness is a major limiting factor in detecting arboviruses, and we recognize that it's really underreported in the region. So just thank you for my group, so all the students that were involved over the years, also the funding that we got from CDC, the MRC, and then the EU, and some local funders, including the National Research Foundation, and BMBF and the G7 from Germany. Thank you very much. Thank you.
Yeah, Mariki, thank you so much for that. You know, I'd like to congratulate you on a you know, very, very good program that you are running there. What a wonderful example of an integrated, holistic study, surveillance study that incorporates humans, animals, vectors across a substantial area of a particular country, and done very, very professionally. You need to be congratulated, Mariki. Very well done. Perfect example for us all to look at and learn from. What I find interesting, this is an example of a university run. It happens so often that some of the very good programs on surveillance are run by universities or other academic institutions, but unfortunately they work in silos, that the results that are generated by wonderful programs do not really link in as effectively as they should to feed into government agencies. The two run parallel to each other and never the twain do meet. You know, I've seen it in several places in Asia here now as well, where universities are doing absolutely wonderful surveillance work, but it does not feed into national malaria control programs, for example. So we need to learn those lessons, and perhaps those can be picked up in the networking group as well, how to achieve better integration or cross linkages between government agencies and academic institutions. Well done, Mariki. Thank you for that insightful presentation.
Thank you.
With the South African example fresh in our minds, we now move on to our final presentation, which is on arbovirus surveillance and response, the Nigerian experience. I want to thank Dr. Udoka Nwangwu, who at relatively short notice made himself available to give us this presentation. Thank you so much. Dr. Nwangwu is a medical entomologist, and he is head of the entomology unit of the National Arbovirus and Vectors Research Center in Enugu, Nigeria. He's a member of WHO's Technical Advisory Group on the development of a target product profile, TPP, for the use of Wolbachia. So we look forward to your presentation. Udoka, thank you, and over to you.
All right, good afternoon, everyone. Thank you, Leo, for having me. I mean, it's a pleasure to be part of this team. I hope you can see and hear me clearly.
Yes, all good. We can hear you clearly. We can see your presentation. Please proceed, Udoka.
All right. This is just like you said, the Nigerian experience of the arbovirus surveillance and response that we have. And very quickly, of course, the time is fast spent. You can see that Sorry, is my slide moving? It's not moving.
No, we're still on slide 1, Udoka. Try again.
Let me see. No.
So you're having a problem in advancing the slides. We're going to give you relax, don't panic. Try again, try again.
Okay, probably what I'm going to do is to try to stop sharing right now.
And retry again. Okay.
Exactly. All right, let me see. Share slides. You can see my slide 1.
All right, try and advance.
Uh-oh.
Not working, Udoka.
It's not.
I'm going to give you another 30 seconds, and then I'll ask our technical backup team if they can pull up the backup slide.
Sorry, it has to work.
All right, I like that. Positive thinking. So try again.
It really has to work. All right. Share slide. Oh, come on.
That's all right. Try again. You don't have a second screen running, do you, Udoka?
No, I don't. That's why I was surprised.
Okay, we're going to give you one last try, Udoka, and then I'm asking our technical team if they can stand by to pull up the backup deck of slides, please. Okay, that's a different view. Try that now.
Let me see.
Interesting this, eh? I wonder why.
Yeah,
Okay, all right. Is that your second slide?
no, yeah, that's my second slide. Yeah.
Okay, well done.
Yeah.
Well done. Well done, Udoka. Okay,
Yeah.
please continue. Well done.
Yeah, of course, this is typical of probably the kind of challenges we face in Africa. So, of course, we keep trying. That's why we have the wrestling.
Well done. Well done.
All right, so it's about the Nigerian experience about surveillance and response to arboviruses very quickly. That's just a presentation slides. I'll leave that for now. Now, first of all, I just want to move quickly to the arboviruses, the major arboviruses circulating in the country. Of course, you can see the yellow fever directly at the top of it, Zika virus, maybe not very recently, McNamara 1954, and then, of course, dengue virus is popping up here and there, not causing major outbreaks in Nigeria, but rearing their ugly heads. And then chikungunya, just like we found in vectors a few years ago in our recent finding, West Nile, and then probably somebody says, oh no, insect-specific viruses are not supposed to be here, but given the number of these viruses we found in some of our recent findings, we felt it was important just to include it here. Nigeria had a period of quiescence in the yellow fever outbreaks for about 21 years. And then in 2017, just in Kwara State here, we had a recorded yellow fever outbreak. And between 2017 and 2020, you can see the country all painted red for yellow fever. 29 states of the 36 and the Federal Capital Territory recording confirmed cases, while all states in Nigeria and the FCT has actually recorded suspected cases. Now, of course, like I mentioned in our recent publication earlier this year for the ISVs, we had to include it here, looking at probably some of these viruses not being pathogenic at the moment, but in time may become pathogenic. And for that reason, we felt it's important to actually just mention it here. It may actually bring up some discussions and probably some things to look at that. Now, how do we do all surveillance here? At the heart of the surveillance is the Nigerian Center for Disease Control, the NCDC, which actually looks at the epidemiological component and then tries to bring in all these traits states through the emergency operation centers. And now these emergency operation centers gives opportunity for the entire states in Nigeria, no matter how remote the areas are, with their disease surveillance notification officers in the LGAs, which are like districts, by the way, and then reporting to the state, and then the state feeding back to the national, that's the NCDC. That's for the epidemiological component. Now, the entomological component is there, of course, that's where we come in. At the National Arbovirus and Vectors Research Center, we look at this, originally looking at trying to work out with quarterly surveillance, working in various parts of the country at various times, and then occasionally bumping into areas because of some reports or observations, doing spot checks at such points. But beyond that, since the resurgence or emergence of yellow fever in Nigeria in 2017, the center has actually reverted to looking at the Sentinel Sites, having Aedes Sentinel Sites across Nigeria. Of course, that is fund dependent. So for now, we have as many as 7 Sentinel Sites, as many as 7 states where we have these Sentinel Sites working and then feeding to NAVRC, which complements what the PED team is doing. And then we look at some of the issues and how it moves forward. Now, when there are outbreaks, for instance, what we found since 2017, of course, there are 5 major actors here. 5 major actors headed by the NCDC, which coordinates with partner support, including, of course, the WHO, the NAVRC, covering the entomological aspect, and then for viruses that are vaccine preventable viruses, we have the National Primary Healthcare Development Agency that can quickly step in if it is something that needs preventive mass vaccination campaigns instantly. That is done. Of course, we can't achieve anything without working with the state. The state actually, where the outbreak occurred, using the State Ministry of Health workers to lead the team, and then the national supports, and then chiefly the community with sensitization and acceptance to actually take and buy into whatever intervention we may have, and then see probably to such occurrences actually not reoccurring in such areas. That's just a very quick overview about the responses. Now, it is important to actually mention that between this 2017 and 2020, when we did some of these rapid responses, when this outbreak occurs, we had some striking findings. Of course, we must give thanks to our collaboration, our collaborators, the African Center of Excellence for Genomics of Infectious Diseases, because at some points we get frustrated. You collect some of these vectors, and the vectors you collect actually stay there with you with a lot of information loaded in them. You don't have the wherewithal, probably the right equipment, the right laboratory to actually move and see precisely what you have. Then we moved into this collaboration with SGID, and SGID helped us in actually looking at what we have in these vectors. We actually assayed for 6 different viruses: the yellow fever, dengue, chikungunya, Zika, West Nile, and Onyonyo virus. However, from our findings in that location, we found yellow fever and chikungunya viruses only of the 6 in circulation in those mosquitoes collected from the outbreak areas. However, Aedes aegypti and Aedes albopictus considered the major, probably between 80 and 90% of the positive pools that we found. It's also important to note that if you look at, based on proportion, obviously you will say that Aedes albopictus had more hands, in quotes, in precisely what happened across the states. However, 7 of the 9 states were areas where we found Aedes albopictus to be positive, to harbor the yellow fever, wild population, by the way, to harbor the yellow fever virus, while we found Aedes aegypti to harbor it in 9 of the states where positive where positive pools were recorded. Of course, it is important to also note that in our study over the years, we found that Aedes albopictus is taking over in the cities. We thought they were relegated to the rural areas, but right now they are taking over the cities here in Nigeria. I know I saw a publication by Kamgang in 2018, and I also Russo in 2020 that also reported something like that in Congo and Cameroon, respectively. So that's just a very quick picture of our findings from some of these outbreak responses in the very recent years that we had. It will be just to mention a few, however little it is, we think is important, talking about the need for surveillance and responses, for some of the little achievements we've had. Of course, in 1991, after a particular yellow fever outbreak in Delta State, Owoibu area, with support from the CDC, a team was sent to that area to work, and they found large populations of a particular vector that they were not very used to. And that actually led to the publication by Savage in 1992, where Aedes-Borne was reported for the first time in continental Africa. Now, also spanning a period of 7 years, we've actually put data together, working in about 15 states and the FCT, and actually looked at what the diversity and distribution of vectors are, of Aedes species are in Nigeria. And that was what recorded in this publication by Chikungunya et al. In 2018. One of the things we've also done is looking at the fact that we have only one institution saddled with responsibility of arboviruses and their vectors, arbovirus vectors in Nigeria. We've actually seen how to work with states, train State Ministry of Health officials to actually see that they work with us. So from these pictures here, you can see these are trained officers working in states. These are OV traps collected, and then from various locations, a staff actually going on supervision, supportive supervision, by the way, to ensure that things move rightly. And then we've had this in over 20 states where we've trained officers that way. Of course, they work in the Aedes Sentinel Sites to see that we generate just a semblance of active surveillance where we actually know precisely what is happening. And then, of course, one part that we don't more often where people miss out is the aspect of insecticide resistance studies. We've also, in all of our Sentinel sites and wherever we go, try to collect vectors, Aedes species, and then look at their insecticide resistance status. And then while we have that, it gives an idea of what's happening in that area. To date, we've had insecticide resistance status of Aedes aegypti, Aedes albopictus, and Aedes leucocephalus, actually looking at what happens in these species and how they respond to the diagnostic doses of insecticides. Of course, I can't talk about all this without mentioning the gaps that we find in some of these things, and hugely, the inadequate capacity, particularly in our molecular biology team to actually do the needful once we come back from the field, and then we can move into the laboratory. If we can do something like that, that would be quite helpful. But unfortunately, we're still struggling with some of those teaching issues. And of course, to mention the issue of training, which is still a very huge issue, and then believing that with the right collaboration and mentorship, and then everything will be possible so that one is able to tell the story of African story by, of course, our own people, looking at how it affects us. Could there be a way forward? Obviously, that there must be a way forward. And that's part of why we're looking at the issue of identifying and supporting national institutions that actually can do the work, institutionalize it in the country, and then see how to support other institutions within the country. The issue of capacity building, just like I mentioned earlier on, to keep one up to date, actually knowing what is happening when you have the vectors or whatever samples you have, and then those are actually working for you and knowing precisely what it is for timely intervention. Of course, the issue of a national strategic plan that will be dedicated to Aedes surveillance, and then one looks at it and follows it through to actually see that we get things done the way it should be. And of course, I mentioned that earlier on, the issue of collaboration. I think I've tried to settle within the 10 minutes given me. And I have to say thank you very much. And thank God the resilience showed we were able to overcome the initial issues. Thank you very much.
Udoka, thank you so much. Wonderful to see what you are doing in Nigeria. Also very interesting, you know, you're telling us about Aedes albopictus that is steadily and it sounds like fairly rapidly, you know, moving into city areas. So, you know, it's not just Anopheles stevensii, it's also Aedes albopictus. So it's a dual threat that we need to be conscious of. Both breed in similar breeding sites, so it helps when it comes to control of both Aedes and Anopheles stevensii in urban areas. So that's one small little advantage in the face of the threats that are expanding, growing, deepening. So thank you so much for that, Udoka. All right, so we're after the breakout group now, we're after the 5-minute break. We're now entering the group feedback mode, where we're going to give each group an opportunity to give brief feedback on what transpired during their group discussion, the results they had. So let's try and keep it brief. This has been going on for quite a long time. So I'm going to ask Sean and your group, I'm not sure who's giving the report back, probably Popo. Yeah, Popo, would you mind just giving us a synopsis of what transpired in your group, please?
I think Popo is ready for a presentation. Hi, Popo.
Okay, yeah, so Popo, whenever you're ready, you can present, unless you're in the kitchen somewhere, rummaging around there.
I'm coming back. Sorry.
Okay.
Share the screen. Yeah. Can you see my screen? The presentation?
Yes. Thank you, Popo. Please go ahead, Popo. Thank you.
Oh, this is I'll be quick, and our group has a less number of questions compared to other group. So this is our findings from our research group discussion, and on the Slido. Thank you everyone for actively participating in the Slido. And I noticed that we have more than 60 participants in the group, but we don't have all of them responding in the Slido for some of the difficulties. So I'm sorry about that if someone can respond. But we have all the chat saved, and if you are typing in the chat, we will save the chat and include in the report. So this is our RAFT 1, the first page, and most of the country, majority are from Nigeria, followed by United Kingdom, Kenya, Tanzania, South Africa. So we have a good mixture of the African country, plus some of the Vietnam and Australia. So we have in the some Asian country, plus Berlin, Switzerland, Ghana. So we have some European countries, Belgium. So this is a good combination in our group. And the second is majority, 83% are from the research and academic institutions, 10% from NGO, and 5% from government agency, and 2% from WHO. So we also have a majority with the research institution, but a small number of a good combination of government agency, NGO, etc. And the next question is about the research knowledge. What are the research knowledge gap? This is very interesting. We spend a lot of time in these questions. People are interested in presenting what are their research needs. And this is our majority of the research needs, playing in the monitoring of arboviruses and vectors, unknown disease burden, transmission pattern of arboviruses, and epidemiology. And majority also mentioned lack of facility and what are the disease trends by the vectors-borne diseases. So this is our knowledge gap, and we have all the records. Some of the responses are smaller in number, so they might not come up on the screen, but we have all the record and the report in the Excel format from Slido. So don't worry if you don't see your answer on this screen, but they are recorded. And based on the previous number of research gaps, I'm trying to pull up the top 10 response to be ranked in the next question. This is our ranking exercise, selecting the most urgent or important issue that requires research attention. So we got the epidemiology of arboviruses at the first top selection, the first ranking, and second followed by the monitoring of arboviruses and vectors, diversity, and the third is the transmission patterns and disease trend, and the fourth research question should be prioritized is what exactly vectors are involved in the disease transmission and vector surveillance, and plus followed by we have unknown disease burden, which should be also focused in the required research attention. And we need to find out what is the impact of this vector control and lack of facilities and surveillance of insecticide resistance. And the last one is spillover on the potential urban environments. So this is our ranking exercise output from the urgent needs or gap of the research based on our participant. We have about 39 participants in this exercise, so we have a less number from the start. And this is the last thing, and for the way forward, how we want to move forward from this research gaps and analysis. So people want to get sent out are happy to receive the sending out the questionnaire for more thorough listing of research priorities and ranking. And the participants are also happy to receive the follow-up questionnaire for more detailed understanding of which institution are working on what. So this is very encouraging for us. We are thinking about to send out a follow-up questionnaire, but we are not sure participants are willing to receive, but this is very encouraging for our group that we will follow up with a questionnaire, additional questionnaire if we have more additional information after this webinar. And the third is follow-up webinar. So we thought that webinars are many times and people will be boring, but this is not true. People are still interested in follow-up webinar to discuss how do we get this research adopted by the research institutions. And lastly, to Leo, they want to ask the question directly. So thank you very much. This is the output from our group, and any question?
Yeah, wonderful. Thank you for that feedback. Well done, Group 1. Thank you, Popo. Thank you, Sean. Thank you, Joe. Are there any questions for Group 1? Remember, we have a big question and answer session coming up as well, but any quick questions?
Yeah. Do you want to add something, Sean? And I'm not sure Joe is still here or not.
No, that's absolutely great. Thanks very much, Popo. I think we had quite a diversity of research questions, actually, and the kinds of things that people were discussing and putting in the chat really did reflect how many unknowns we're dealing with. So I think there's definitely a great need for more research in more places, both on the viruses that are present, also on the vectors, and understanding. Also, there was some discussion about methodologies. So some need to compare and standardize methodologies, perhaps, to improve our ability to generate data on this.
Yeah, no, well done, Group 1. Thank you for that. You had a very strong group there, my goodness, good participation. So, all right, thank you, Group 1. We move on to Group 2. Florence, I think you got the short end of the stick. Not many participants, but I'm sure you had good quality input. Callista, are you going to give us some feedback?
Yeah, so hi everybody. I'll be presenting on behalf of Florence and Breakout Group number 2, where we talked about networks. There were around 40 participants in our breakout group, but then on Slido, around 20 to 25 people reacted. So in terms of which networks already exist in Africa and that provide some support for arbovirus issues, many people included PAMCA, Africa CDC, WASUN, which stands for West African Aedes Surveillance Network, but some others also mentioned Global Vector Hub and PVEC, so the partnership for increasing the impact of vector control in Malawi. In terms of the areas that were not covered by the current networks and need to be, based on the current knowledge of gaps or needs, The areas that were mostly mentioned by participants were community engagement, diagnostics, ecology, genomics of arboviruses, arboviral surveillance, and sharing data on arboviruses, as well as gaps in capacity and training and job opportunities. And there was also one mention of modeling. And in terms of the support that should be provided to networks, most people replied with financial needs, and this also included equipment, but there was also a need for training opportunities, data sharing, so establishing some kind of database for specialists. And in terms of the core objectives and activities that would be needed for an African research network for arboviruses, most people mentioned surveillance, in particular, exchanging surveillance systems between countries. There was also a lot of mentions of capacity building, networking events, monitoring and alerts, and also sharing data again in quarterly meetings, and also connecting research centers with common activities. And in terms of our last question, what would be the appropriate actions to move these discussions forward? Most people reacted with having online survey questionnaires to find out what priorities are needed for networking, and also webinar related information. So follow-up webinars on findings, and also distributing the findings of webinar workshops. Great, that's all from me. Thank you.
That's great, Callista. Thank you, Florence. Thank you, Callista. Thank you, participants in group 2. Clear, crisp, and intuitively satisfying results. Well done, group 2. So group 3 was Raman, Corinne, and myself, supported very capably. Wulan, thank you for all your help. Wulan, are you going to give a bit of feedback?
Yeah, sure. Thank you very much. So this is from our group 3, surveillance and control capacity building. 40 people joined this group, but only 25 to 30 people have responded to all the questions. Then, so most of them were from African countries. Nigeria is the most, and then followed by Democratic Republic of Congo, and then Kenya, and followed by other African countries, Uganda, Malawi, Cameroon, etc. And then for affiliation sector, most of them were from research or academic institutions, 66%, followed by NGO and government agencies, 7%. It's only 7% here. And some people from UN agency or WHO also joined here in this group. And then when we asked questions like what capacity strengthening that they will need, most of them responded that arbovirus detection pathogens, arbovirus pathogen detections, and then vector surveillance training, and vector surveillance for arbovirus vector is one of the most voted answer. Then when we put this on the next question for get the rank into top 6, then this is what we got. The first rank is training on lab capacity, including vector and pathogen, and the second one is a vector surveillance and taxonomy, and the third is arbovirus pathogen detections and molecular identification and bioinformatics, and then followed by availability of training materials and arbovirus gas management, and also this is modeling and protection, and also followed by 2 other options here, 2 other rank here, more acute facilitators and also dengue management. Then when we ask this question, please identify group involved in relevant training in Africa. So you can see here from these boxes, many people mention about, most of them are, I think, from because they are from Nigeria, and then many people mention about national arbovirus, and one of the answer is, sorry, National Arbovirus and Vector Research Center, Nigeria, for the topic of vector surveillance. Then, yes, that's just the example. And then for the way forward, people mostly chose structure online survey questionnaire to develop a more granular understanding of specific country needs. And the second one is to prepare and distribute the findings of a webinar work groups, and then follow-up webinar on findings and group discussion. I don't see any other ideas in chat box, so I think we can just forget this other option. And then, yes. And when we ask more about sharing webinar and its frequency, most of them voted for every quarter. So I think they're happy with webinars. Yeah, I think that's all from me. Over to you, Leo. Thank you.
Thank you, Wulan. And thank you, Raman and Corinne. We now thank you for all the working groups, and thank you to all our audience. It helps give us some guidance as to what the general patterns of needs are, and how to take this forward through a consultative process, questionnaires, and so on. So we come to the question and answer session. I just want to mention we have the privilege of having as a panel member Dr. David Choasi, who is a senior scientist at the International Center of Insect Physiology and Ecology, ICIPI, in Nairobi, Kenya. He's a medical entomologist and obtained his PhD at the University of Pretoria in South Africa. And his research focuses on transmission biology, ecology, and epidemiology of malaria and arboviruses. Thank you, David, for making yourself available to help answer any of the questions that may be forthcoming from the audience. And I presume that many of the questions, I'm not sure how many questions will come, but hopefully there will be some questions emanating or resulting from the presentations at the beginning, probably some from the working group activities. So open to questions and answers. So we've got to scroll through the chat, presumably. I'm not quite sure if one of our technical people captured. If you have a question you would like to ask, please feel free to raise your hand and start speaking. Unmute yourself and please go ahead, ask a question.
Okay, good afternoon, everybody.
Hi, Ebuko. Please go ahead.
Okay. Thanks for putting this together and for bringing these guys to give us something that has wowed us. The presentations all through were great. Okay, I think my question has been captured here, but maybe I will reiterate it and for emphasis sake. Okay, I was asking based on the chat, or based on what Mr. presented about Nigerian experience, asking the map. We have some areas that are not covered with red. That is the areas where we have non-surveillance on those areas. So I wanted to be sure, those areas, are they actually vector surveyed, or arboviruses outbreak in those areas? If they can make it clear for some people that want to sponsor the remaining states, at least Nigeria will have a very wide coverage that when you say in arbovirus-borne diseases, we can say in Nigeria, the whole places are this, look at what we have here, and this is sponsored by this. So I want Mr. Udoka to make it clear for people that are interested in that. Thank you.
Ebuka, thank you so much. Udoka, are you still with us? Are you able to respond to that question?
Yeah, thank you, Prof. Maybe I will use this opportunity to apologize for those who found my presentation quite fast. Thank you very much, Ebuka, for the question. I think the map we're presenting there was actually the spread of arbovirus, yellow fever positive cases in Nigeria. Remember, I said in the presentation that as of 2017, Nigeria has had a period of 21 years quiescence without any report of yellow fever. Then from 2017, it was recorded in Kwara State. And then from Kwara State, it spread to 29 states where cases of positive cases were recorded. It wasn't about vectors or anything. It was just talking about cases that had recorded yellow fever positive cases, 29 states and the FCT. So the 7 states that are white up to date as I speak are yet to record confirmed cases of yellow fever. Thank you.
Udoka, there's a second question. If you look towards the bottom of this list on the screen, what is the incidence of dengue fever in Nigeria and neighboring countries? Do you have any response to that? Dengue fever prevalence in Nigeria and surrounding countries.
Actually, thank you, Prof. Actually, I do not have that data. However, I know, like I said in the presentation, what we have is just sporadic cases. For instance, in 2021, there was a co-infection of yellow fever and dengue in a particular patient case from Anambra State, and unfortunately, we lost the patient. So those are the kind of things you see. And then some studies we are doing right now, you find the dengue NS1 gene detection in some of the arbovirus vectors around us. So unfortunately, I don't have that data. And I want to reach out to the individual probably from the chat room to see if you can link up, I can get that and send it across. Thank you.
Wonderful. Thank you, Udoka. So I'm going to go down from top to bottom down the list on your screen here. I just want to check. Rahman, are you still with us?
Yes, I'm here. Yep.
All right. So Rahman, you may have read the question here at the top of the list from Francine. She's asking, sorry, I'm getting something.
Sorry, Leo, the answer is given in the next column already.
Oh, my goodness. Thank you.
So the side column is the answers.
Yeah, I see that now. Sorry, I didn't notice that before. Well done. Thank you, Rahman. That does away with questions 2 and 3 as well. Then there's one here from Michael McDonald. Can we expand the RBM, Rollback Malaria Vector Control Working Group to include Aedes? I'm not sure if that's a bit of a rhetorical question, Michael.
Sorry, but with Rahman on the line, you know, the Global Arbovirus Initiative, one of their goals is to break down the silos between the malaria programs and the arbovirus programs. And so I think the same goes for AppMen, that we want to change the meaning of the M from malaria to mosquito.
Ah, Michael, excellent. Yeah. So I'm not sure if there's anyone who wants to volunteer a response to that. I think we're all in support of the sentiment, Michael. I think all endorse that suggestion. Yeah, do you have any comment to that?
Not really. Actually, me and Michael, we have had this debate for years together. So
yeah.
He knows exactly what the problem is.
Yeah.
So the issue is we have come to a point where our managers, senior level decision makers have to take that decision. But today, as I presented in the beginning, we are moving towards more urbanization. We are having invasions of species. The mosquitoes are spreading without us noticing it. And at the end of the day, the consumer or the public, what is their problem? Their problem is mosquito. They are not bothered about Aedes or Culex or Anopheles. It's a mosquito bite. So the issue is we need to holistically manage this. That is one part of the story. Second challenge we have is South America, Asia, and almost majority of these countries, malaria is very low. And actually, dengue is the biggest headache. And arbovirus is also. And this is again linked to urbanization, erratic water supply, etc., etc. So here we need to work together to address the issue which the politician will have to deal with. Because I remember a very famous person inquired in a couple of Asian countries whether malaria is the main problem, and they got back immediately the reply from the president saying malaria is not our problem. It is dengue and Aedes-Borne diseases.
Yes. Yeah.
So think of Brazil, think of Indonesia, think of all these countries. Malaria is not in the top 10. So we really need to think from an entomological perspective. What Mike is suggesting makes a lot of sense, but unfortunately, this is not in our hands.
Yeah.
The decision has to be made far above, and let's wait and see.
Yeah.
Stop there.
Thank you for that, Rahman. Wonderful. Michael, keep banging your head against the wall. At some point, the wall must crack. So keep on. I'll support you. I'll bring the head. I'll bring the head. All right. Did somebody want to respond?
No, I just wanted to, the idea of looking at rollback malaria beyond just malaria to include Aedes-Borne viruses, I think is a very commendable idea. One is that, especially in the African context, we do not know so much about the behavior of Aedes. The supposed Aedes aegypti or Stegomyia species, where we can borrow exactly from the case, it's in Southern America, where there's been a lot of advancement in terms of coming out with advanced control tools, some of them indoors. But one question I always ask is, do some of those tools, can they actually be implementable in the African context? Given that in some localities, like in East Africa, majority of what we see in terms of resting patterns, and even there are many outdoors, in some localities, although this is just based on preliminary work. But I think that consideration to try and integrate that into the broader perspective of mosquito control, I think it will be very, very important. And this will be backed by detailed study for us to really understand the behavioral divergence vis-a-vis populations of Aedes in Africa, vis-a-vis elsewhere across the world. Thank you.
Yeah, thank you for that. It all points again to the great need for additional research. I mean, Emmanuel and Gildas made the comment, there are countries in Africa that are reporting Aedes-borne arbovirus outbreaks, but they are listed as not having recorded either Aedes aegypti or not having Aedes albopictus recorded yet. So, it just points to some basic surveillance is not being done, has not been done, and a great need for strengthening those practices and the capacity to do that. So Marike, I just want to find out, are you still with us? Professor Venter, are you still with us? So Joe, I don't think we're going to be able to answer your question there about Japanese encephalitis. And also Olivier Brett, also addressed to Marike. Felicity, are you with us? Felicity Birch? Nope. Okay. Udoka, I think you're still. Oh no, you've answered those. So sorry, the black line at the bottom is covering the bottommost question. I can't see that. Oh, okay. It's from Ephraim. Dr. Udoka, how did you determine transovarial transmission of arboviral diseases? I think you can see the question right at the bottom there. Do you want to respond to that one, Udoka?
Yeah, thank you, Prof. Though I think I've answered it, but maybe I'll answer again. I answered on the chat room. I was talking about the fact that the Transovarian transmission actually come from handling of the immature stages, when probably you handle from the eggs to the larvae and pupae, and then raise your adults and probably test that population. And then you can actually determine those ones that are transovariant from those that they have possibly collected, gotten the viruses from other sources as adults. However, that was not part of the major part of what we did, but some part of our work captured that. I've answered that on the chat room. Thank you, sir.
Okay,
Yeah.
Thank you, Udoka.
Yeah, just to add.
Sure, go ahead.
Yeah, just to add that you can do it also by testing the male adult collect on the field.
Yeah, yes. Yeah, Basil, thank you very much. Yeah, actually, we separated males as well. Of course, that was also ways of actually telling us that those ones were actually transovarial. But of course, you know, there are cases of venereal transmission. However little that may be, that becomes another issue. But we actually separated males and then be able to talk about that in that sense. Thank you, Basil.
All right, that sounds like it's exhausted the list of questions, unless there's somebody that wants to voice a verbal question. Anybody, just jump in. If you want to ask a question, now's your chance, because I'm going to end off now.
Good day, everyone.
Hello, please give your name. Hello. And then please give us your name and ask your question. Can you hear me?
Okay.
Yeah. I'm not sure what the problem is. Please, so is it Sylvester that wants to talk? Sylvester, you seem to have a problem with your voice, your audio. I'm very sorry about that. Try again. Sylvester, we really would like to give you a chance, but we're struggling to hear you. Sylvester, I'm so sorry. We really would have liked to have heard your question, but technology is a problem. So I just want to remind everyone that you'll be prompted very soon to respond to the feedback poll. We ask you, it's very short. Please just take a minute to respond to that feedback poll to help us understand what we got more or less right and what we need to improve on and so on. It really helps us when it comes to a next webinar, which we would like to do. Other than that, I'd like to thank all our various speakers for their highly professional presentations. Thank you to our breakout group facilitators for your professionalism and your help. Thank you to several individuals who stood by to help, but in the end were overtaken by the unfolding of events. And I think you have Dr. Chouassi in particular. Apologies, David, that we did not do justice to your expert capabilities. This workshop would not have happened and certainly would have been a shambles if it were not for the excellent support from our backroom team. So I want to say thank you, Willan, thank you, Popo, Callista, Olivia, Rachel, Simon, and others I may have momentarily overlooked. Thanks also to Constantina at RBM VCWG, our colleagues at Global Vector Hub, Wasson, Pamka, Appman, and elsewhere for your efforts to disseminate the flyers and notices. And then perhaps most of all, not perhaps, definitely most of all, thank you to you, our audience members. You have made all this worthwhile. So thank you everyone for your time. We really appreciate it. We hope you feel it was worth your while, that you've benefited from this. And hope to see you at the next Arbovirus webinar. Thank you, everyone. Have a great day.
Thank you, Prof. Thank you all.
Thank you. Bye.
Thank you, Doka. Bye-bye, everyone.
Thank you to everybody.
Thank you.
Thank you. Thank you.
Thank you.
Thank you, everyone. Thank you.
Thank you.
Hope to hear from you.
Thank you.
Thank you all very much. Thank you so much.
Bye.
Bye now.
Danke.
All right. Thank you, everybody. Thank you, Dr. Leo.